Hello, everyone, and welcome to today's webinar. My name is Emily Taylor. I'm the Vice President of Advocacy and Engagement here at SolveME, and I'll be your moderator today. Today, we're discussing occupational therapy, the role it plays in the care for ME/CFS. And just a couple quick housekeeping items before we get started. If time permits, we will have a question and answer session. You can enter your question for the moderator, for myself, and for our panelists to consider by entering them in the Q&A box, which you can see at the bottom of your screen there with the two little bubbles facing each other. You can click on that box and type in your question, and we'll do our best to get to all the questions we can today. We have closed captionings for folks who need that accessibility feature. You can do that by clicking on the closed captioning button on the bottom of your Zoom screen or on your phone, and that you can turn on those captions and read along with us as we continue the presentation today. Just a gentle reminder that all of our webinars are recorded and will be available on YouTube at our youtube.com/solvecfs channel, the SolveME channel on YouTube, or on our website. You can access it there as well. Just another gentle reminder that SolveME does not provide medical advice. We are not endorsing this presenter or the content of the presentation. If you are going to use any of the recommendations, we strongly recommend you consult with your doctor. Do not use experimental or non-FDA approved treatments without medical supervision. And of course, these webinars are for informational and educational purposes. So with that, we'll begin our occupational therapy in the care for ME/CFS webinar today with the one, the only, the great Amy Mooney. For those who are members of the ME/CFS community, this is probably a household name for you. Amy is an occupational therapist with over 20 years experience, and she's worked in a variety of settings, including school, early intervention, home health, and clinical practice. She specializes in care for individuals with chronic disease, and Amy has been involved in numerous ME/CFS educational programs for medical providers, including advocacy campaigns for patients and caregivers. Amy is interested in increasing awareness about ME/CFS and hopes to inform her fellow occupational therapists about how they can support the care and provide treatment for people with ME/CFS through occupational therapy. Amy, I could go on and on about your amazing background, but I think it's best to just turn it over to you and hear your amazing insights for today. Thank you so much for joining us.
It's a pleasure. Thank you for inviting me. So, okay, I will share my screen and we will begin. One quick second. Okay, all good?
Yes, clear as crystal.
Okay. So, yes, this presentation is on occupational therapy. It's the role of OT in the care for people with ME. And I am really honored to be part of your team. So thank you for inviting me. So for this presentation, I just want to go through a basic outline. I want to offer people with ME the tools for accessing the care you need to improve your daily living. And for the healthcare providers that are in this audience, this presentation hopefully will offer a framework to assist and treat ME, specifically for the considerations of PEM. And that includes individuals with long COVID who now meet the criteria, the diagnostic criteria for ME. So ME is an illness that is not invisible. It is hiding in plain sight. The disease is misunderstood, patients are not believed, and the research is not prioritized. People with ME are forced to live or leave the lives behind that they have once lived so gloriously. They are the shells of the former selves. Each individual with ME has unique roles and occupations that bring individuality and quality to one's life. The disease has robbed you of your occupations as a child, as a sibling, as a parent, a grandparent, a friend, a dancer, photographer, all of the things that make you you. It is the role of an occupational therapist to help individuals access and perform their occupational roles despite disease, injury, illness, and impairments. What is occupational therapy? And it's OT for short. Occupational therapy is a healthcare profession. It's typically working in clinics or hospitals, schools, home health settings. that focuses on the activities we do every day that make us uniquely who we are. These activities of daily living are called ADLs. They are the self-care tasks: grooming, eating, toileting, resting. And they are also instrumental activities of daily living, which are IADLs, which are the independent, complex tasks of living. And those include home care, child care, work, school, and leisure. Occupations are the fabric of our identity. And those, like I said before, are occupations as a parent and a child and a gardener and a traveler. Those are all considered your occupations. But you may ask, why isn't an occupation the same as your profession, as maybe a doctor or a teacher? And not in the therapeutic world. Your occupations are your roles of your life. It's the roles of an infant or a child, an adult or an elderly, that are unique to your cognitive and your physical and your social and emotional stages of each of those developments. Those are your occupations. And the goal of OT is for participation in meaningful and purposeful activities. Occupation is meaningful when it allows an individual to fulfill a goal that is personally or culturally important. And occupation is purposeful when it is determined by the individual's unique needs and interests in a particular environmental context. Uniquely occupational therapy. The goals and the evaluation and goals are developed based on an individual's needs and wants to do and how they do it. The evaluation, in basic terms, examines why can't the individual do what's needing to be done. The evaluation assesses, for example, motor, cognitive, sensory, and all the other domains. And it uses evidence-based assessments to determine the path for the treatment. And this path is referred to in the OT world as frames of references. These frames of references are the structure or the framework to guide therapeutic intervention. So we've taken an evaluation, we've looked at what the needs are, we've assessed the performance, looked at the barriers and the supports that the individual requires. And based on those needs, we develop a treatment plan, and we use frames of references to support that. And here are just a few of the examples of a frame of reference. The sensory integration, or NDT, the neurodevelopmental treatment, proprioceptive, neuromuscular, biomechanical, and cognitive behavioral. There are many, many pieces or dimensions to what an individual needs when they have motor or sensory or whatever unique needs they have. And the goal is to support the individual in meaningful and purposeful activities and improving the quality of life. And how does this fit in with myalgic encephalomyelitis? Well, myalgic encephalomyelitis is a chronic multi-system disease characterized by systemic exertion intolerance, resulting in significant relapse after exertion of any sort. And that can be physical, cognitive, social, emotional, sensory. I know you know this piece very, very thoroughly. And ME is a multi-system disease, and we need to start offering frames of references that identify and support these impairments. The overwhelming list of symptoms that people with ME described is a call to action for healthcare providers to create a better treatment framework. It's not one-dimensional, it's multi-dimensional, and we need to step up our game. Let me see, So the next slide looks at post-exertional malaise. It's the hallmark of ME. It's the hallmark symptom, the group of symptoms of ME. It's the abnormal physiological response, also referred to in the long COVID community as post-exertional symptom exacerbation. PEM is like drowning in cement, and all of the symptoms are rolling over you. People with ME describe PEM as being poisoned. PEM is the worsening or the exacerbation of your symptoms and function after exposure to exertion that were previously tolerated. PEM may be immediate following exertion or delayed by hours, days, weeks. PEM may be episodic, meaning one event causes a response, or it may be cumulative, multiple stressors adding up to the PEM response. And patients can experience an exacerbation of one or all of the symptoms and a further reduction of functioning. It may take hours, days, weeks, or longer to return to baseline. And sometimes, unfortunately, a new lower baseline is not established. The symptom exacerbation is out of proportion to the stressor, and the symptoms are unexpected. You don't usually expect to have sore throat or sore lymph nodes or cognitive fog after working for 20 minutes on the computer, answering emails, or taking your child to school. These are unexpected responses. And looking at the severity of ME, it's typically described in 4 categories as mild, moderate, severe, and very severe. People describing their ME as mild will probably participate in activities, and their symptoms may go unnoticed to the general public, but it's not unnoticed to the individual. They feel it. They miss events, they disappear, and they need to make alterations to their schedules. They are mobile and typically self-caring. They are able to manage light domestic and ADL tasks, but with difficulty. Employment and school duties are performed with modifications, and they have significantly reduced activity and frequent breaks. Moderate ME is reduced mobility and may use a mobility device, but for energy conservation purposes. Typically 50% reduction in pre-illness activity, unable to work or attend school full-time, require many extended rest periods, and what I consider as being home tethered. And severe, typically able to carry out minimal ADLs with moderate amount of assistance from a caregiver, require daily caregiver assistance, severe cognitive difficulties, decreased information retention, and deficits in short-term memory and word finding, may need support for position and movement, and is considered mostly homebound, and also bed tethered. And then finally, very severe, unable to mobilize or carry out ADLs for themselves. They need assistance with basic functions and position care, often extremely sensitive to stimuli, bedridden, and limited bed mobility. ME is not the result of false beliefs or deconditioning. These assumptions ignore the broad evidence of neurological, immunological, autonomic, and energy metabolism impairment. They also suggest that ME, fatigue, and disability are the result of inactivity and deconditioning. And they fail to improve functioning and are detrimental to the health of this population. Research has shown that the first couple of years of this disease process is very important. Access to care is crucial. Adolescents and patients who get treatment early, especially those identified early in their cases with substantial care, appear to have higher success rates than people with longer duration ME being greater than 2 years. Quality and access to care are vital in the management and treatment for people with ME. And OT has so much to offer people with ME. OTs must take an active role in the care for people with ME. So what does OT look like for people with ME? And how can OT support people with ME? Occupational therapy's holistic perspective and philosophy is well suited to offer people with ME the support for restoring, rebuilding, and redefining occupations lost due to the unique characteristics of ME. And this is what I perceive as being traditional OT guidelines. The traditional OT approach focuses on the deficits that present in front of you. What do you observe? What does the therapist see when the patient enters the clinic or the hospital or the school? The goal and the treatment focus is to improve and increase activity performance, which then leads to restored health and functioning. The traditional strategies are modeled on the assumptions that the physical components of increasing strength, range of motion, and endurance, along with illness beliefs, of coping strategies, and the psychological components of illness beliefs will improve the functional outcomes. But that assumption is only accounting for the observable feature of the iceberg. There's a whole hidden beast of the disease out of view. The exacerbation of symptoms and crash will happen away from public eye, and patients will self-report fatigue and a slew of other symptoms that prohibit them from performing normal ADLs and their occupations. They can do the activity in the clinic, but cannot maintain that level of functioning at home. Patients are too unwell to maintain a therapy schedule. And for this, the therapist assumes that the patient must be well and off living their life, or that the patient is unmotivated and not interested in continuing or not able to continue therapy. But when you flip the iceberg over and focus on the hidden side, you will see the hallmark symptom of PEM. The flipped approach focuses on what was once below and submerged. What is seen in public life or in the clinic is not the essence of the disease. Improved quality of life will only happen when treatment, care, and support is focused on the flipped image. The essence of PEM is what is happening after the activity, what is happening during the recovery. The focus of OT is to set the goals and measure the outcome on the recovery, not the activity. Here are some of the PEM-sensitive guidelines that I've developed. The first one being PEM needs to be identified. Determine who has it and who does not. Identify PEM by looking at the severity and the symptoms. And then determine the core occupations. What is it that the patient needs to and wants to do? And develop a treatment plan that is within the limitations of PEM. And that is symptom management, pacing for PEM, modifications and adaptations, and patient and caregiver education. Utilizing strategies. The strategies for care should utilize a comprehensive approach with multiple frames of references. Like I said before, you use the evaluation to determine which frames of reference are needed to even be added to the treatment. And these frames of reference, again, are the examples are sensory integration, PNF, NDT, biomechanical or cognitive behavioral, and there are 25 more frames of references in the OT's bag of tools that we are familiar with using. And then finally, utilize guidelines such as heart rate biofeedback, checklists, self-assessments, and also the protocols for comorbid diseases. And finally, personalized models of care is as unique as each individual that an OT encounters, and it must be assessed and determined case by case. So first, screening for PEM, and the US ME CFS Clinician Coalition has put together some really great tools. And one screening was just published a few months ago by Mayo Clinic. So that one is referenced here as what happens when you engage in normal, previously tolerated activities, physical, cognitive exertion, and the activities of daily living. And how much activity does it take for you to feel ill or trigger your illness worsening? And how long does it take to recover from physical, cognitive effort? And do you avoid or change certain activities because what happens to you after you do them? Patients are encouraged to keep daily diaries of symptoms and your activities to help describe your PEM. And not all fatigue is PEM. And that is where a specialist really needs to learn and fine-tune their skills to understand the differences between fatigue from an illness or condition that already has a root treatment plan, or somebody that truly has PEM. So determining the severity and the severity level. You identify PEM and you come up with the severity and the symptoms. Are they mild? Are they moderate, severe, or very severe? And within each of those levels, these two components need to be described. Quantity. What is the battery charge? Is it 50%, 20%? When does the crash happen? And then quality. Does the crash reach the exertion window fast and unpredictable? Or is it a slow process and you come up with signs that you can start to recognize? How quickly is the crash reached? And the goal for any severity level is to maintain a safe and secure exertion window. And next is symptoms, identifying the primary symptoms. What are the symptoms? Make a list of the top issues. If you had a magic wand, what would you first get rid of? I heard that from Dr. Bateman, and I think it's a fabulous way to think of it. What is it that I want to get rid of? I'm not going to get rid of everything, but what are the ones that are the top? And if I could get rid of some of these or have some under control, my life already is showing improvement. And throughout the entire process, keep your core occupations as the main focus. How are the symptoms affecting the ability for you to perform your core occupations as a child or a student, a mother, father, grandparent, dancer, artist, any of the things that you want to do in your life? Core symptoms. We are very familiar with these core symptoms of ME. And the symptoms are unique to each person and will vary in intensity, often changing throughout time. Throughout hours, days, and even looking back 6 months or a year ago, those symptoms may change. It is important for people to track your symptoms so that you can communicate these needs and these progressions or regressions with your medical team and develop a plan. And with the symptoms identified and prioritized, like if you have a magic wand, what would you get rid of? The OT will determine the frames of references that best align with the treatment strategies with symptoms. These frames of references will start to offer strategies and methods to managing symptoms. If somebody presents with a whole lot of sensory intolerance, they can start to use sensory integrative treatments. They can change and modify the environment, knowing that the sensory is a top piece, or positional, or musculoskeletal, or any of the symptoms. They need to start being prioritized. And from this image, I want to remind you of the elephant in the room, PEM. PEM is the hallmark symptom of ME. And once the threshold is passed, all of the symptoms come crashing like a tidal wave. It is vital to avoid the crash. And putting the body through a repeated cycle of dangerous and harmful. The boom bust cycle. Two important points that I want to make is you do not need to and should push through the task. Pushing through will exacerbate the symptoms and cause a crash. There is no guarantee that the individual will return to the pre-crash baseline, and constantly going through that boom bust cycle will only cause more damage to a poorly functioning system. And the second, wherever the battery level is in the charge, you need to leave space for recovery. And I know this is easier said than done. How do you do this? You start by learning how to pace. Pacing. Pacing is a strategy for managing exertion for a task or tasks over time. And 3 categories of pacing I've described, hopefully to cover people with normal, everyday, without significant health concerns. Pacing for individuals that you see and you encounter every day. These strategies are utilized every day, multiple times a day for big and small tasks. It's those people saying, oh, I just got a bad night's sleep. I need to rest. I need to pace my day to get through it. I need to drink more coffee or do some things that will make me regenerate. That's for pacing for individuals without significant health concerns. The second one is pacing for therapeutic strategy. And this is for those with intact metabolic systems and do not have a disease of post-exertional malaise, but they do maybe have health concerns or another diagnosis. This strategy of pacing is a more complex process, But with medical professional guidance, most individuals can self-assess and adjust their levels of activity and their expectations. And then we have pacing for PEM. It is for those with the disease of impaired metabolic functioning. Pacing for PEM is a complex, specialized, and absolutely vital strategy for managing a task, exertion, and recovery over time. And pacing for PEM must account for the exertion prior to, during to, and post-task. And pacing for PEM is a lifestyle of symptom management. Misconceptions of pacing for PEM: that pacing will cure ME, and this is false. Pacing will decrease symptom exacerbation, stop the boom and the bust, and offer decreased in symptom intensity. And number two, pacing is the same for all diagnoses, and this is also false. Expanding or grading the amount of exertion performed, AKA graded exercise, will not increase tolerance or recondition for diseases with PEM. People with ME's core biological dysfunction is not rooted in deconditioning. They have a chronic multi-system disease characterized by systemic exertion intolerance. They have an impaired metabolism or metabolism functioning. Graded exercise is not pacing. Increasing exercise over time or intensity is a strategy. And it is a strategy utilized in models of care for individuals, but it is not sensitive to diseases of metabolic dysfunction and should not be used in this population. And third, pacing is one activity, one task in length, and that's false. Pacing is a collection of the past, the present, and the future activities. Pacing is being mindful of what has led to one's current window of exertion or your energy envelope, and identifying what the priorities are for immediate, short-term, and long-term performance. Pacing is a lifestyle, and that is the truth. Pacing for PEM. Here is the nuts and bolts of pacing for PEM. We've already talked about how to identify the severity and symptoms. And now the heart rate biofeedback and self-assessment piece, they are tools and monitors that assess the quantity or the quantitative physiological changes or challenges of stressors. Other tools can be used, such as checklists and scales. Those are qualitative measures, and they're checking and asking about the cognitive processing or sensitivity to sound and light. And those are your self-assessments. And then there's task and activity analysis. This is prioritizing, planning, and pacing. Prioritizing is, what do you really want to do? What are the core tasks that are purposeful and meaningful to you? And then planning, what is it? What will it take to get it done? Assessing the components of the task by analyzing the physical, the cognitive, the sensory, environment, all of those demands on the task. Can barriers be lowered or removed given the extreme considerational needs for protecting against PEM? Can adaptations and modifications be used to lessen the exertion? And pacing, how can I get this done with what I have? The term energy envelope is describing the energy required for the activity over time. The energy envelope is the balance of the pre-activity, the exertion, and the recovery. How much energy is available before, during, and post activity? Will the battery be depleted prior to the activity's completion? And how much battery is needed for X amount of exertion? And then creating space for recovery. Every activity requires battery power, but you need to have power for your recovery as well. And how do we get there? Well, task analysis, activity analysis, and then adaptations and modifications. First, doing a task analysis. What are the jobs that you need to do? What do you want to do? This may be running errands, going to the store, doing computer work, making a meal, taking a shower, talking to friends. Task analysis is taking inventory of the work or the jobs and deciding what is the priority and where is it on the to-do list? And is this meaningful or purposeful? Do I really need to or want to do this? And then activity analysis is the process of breaking the tasks, such as grooming, into individual activities, such as brushing your teeth, washing your face, combing your hair, and determining the conditions necessary to achieve that goal, such as, can I skip part of the morning routine and do something in the evening? Can I do one activity in the evening or even not at all? And this analysis includes breaking down the components of the task into time, physical, and environmental context. This involves planning and pacing. Plan, what will it take to get the activity done? And pacing, how can I get this done with the energy and the symptoms that I have? And finally, providing modifications and adaptations. Adaptations are the provisions or the changes to the environment or the activity that help you achieve a desired outcome. And modifications are the changes to the outcome to meet the individual's needs, such as cutting down the amount of work that a student is required to do, or changing the time that an activity is going to need. So adaptations are maybe giving you change the environment, but the modification is changing to the task. And looking at activity analysis in a little bit more detail, by taking the inventory of your symptoms, and a pattern can start to be identified and beginning to manage those symptoms. So activity analysis for PEM, broken down into sensory, cognitive, physical, and social emotional, have a lot of dimension to it. Every activity has stressors. Are certain activities more taxing on physical or cognitive, sensory, or emotional? And how will they change or affect your symptoms? So here are examples of stressors. Now think about a task such as grooming. And one activity that you do that's a priority of your day, for example, brushing your teeth. So where is it located and how many stressors are involved? For a person with mild ME, you may be standing at the sink. You're doing the task, or I'm sorry, doing the activity in the bathroom at the sink. But for a person with more severe ME, they may be in a reclined position. So looking at the environment will really help lessen the load in multiple ways. So here's a breakdown of just potential stressors. Sensory, looking at visual. What are the lights like in the room? Are there bright and glaring? Are there loud patterns that you're looking at? And are screens blinking or distracting? Those are all taxing. Those are all stressors. Auditory. What are the background sounds? Do you hear a lawnmower or a noisy neighbor always in the background? Those things also are stressors. Touch, what is the material like? What type of touch is the person experiencing? Is it light touch, deep pressure touch? Is it constant or is it intermittent? Smells, are there strong smells coming from the kitchen? Is the therapist or the caregiver wearing really strong perfumes? Taste, what's the taste of the toothpaste? What is the taste of even the water? Is it metallic? Proprioception, proprioception is your body's awareness to movement, pressures, sensation through joints and soft tissues and internal regulation. So even proprioception it's considered sensory, and it is also a taxing stressor. Cognitive, there's a lot to say that somebody has brain fog. There are many, many components to cognitive: memory and learning, language, executive functioning. When tasks have many components, or when activities have many components to it, that's considered executive functioning. Complex attention, social cognition, visual perception. And then physical, there's gross motor and fine motor. Fine motor is things that you might do with your hands, and dexterity. Gross motor are the big movements of your body that needs to go and move or get you from place to place. There's also autonomic regulation, such as regulating your temperature, your blood pressure, circulation, and your digestion. All of these things are physical demands that, knowing where you perform the activity, how you are doing it, is all part of exertion and stressors. You are not doing this activity for strength and range of motion purposes. People with PEM or people with ME are doing it because they need to conserve, they need to protect, and they need to guard for their quality of life. And here are some examples of adaptations and modifications: simplifying the components of the task or the assignment. What are the key learning components? Don't add more busy work. What are the core objectives to that activity? Flexible timelines and schedules. Outsource or eliminate work. Can meals be prepped? Can things be done by other people? Can students borrow notes from other students? And then provide assistive technology, electric tools, remotes, timers, recording tools, and disability placards. Positional support modifications, such as wedges, bolsters, bedside tables, adjustable beds, scooters, wheelchairs. So coming back to this framework, I want to focus on the task of hygiene and the activity of bathing and grooming. Hygiene varies and looks completely different for people with mild to very severe ME. In this slide, I'm looking at mild, bathing, and grooming. And just looking at the time, can it be done in the morning, evening, every other day? Broken up into different sequences of activities. And the physical, standing in the shower, can you sit in the shower, sit on a bath chair, put your feet up, recline in bed, all of the things that can be changed. There are no strict guidelines for how something needs to be done. The environment, what's the light like? What's the sound, smells, touch, and temperature? And then adaptations for mild, breaking the activities and tasks into smaller activities, sit to perform activities, keep your materials close to you, use adjustable shower heads, use electric tools, simplify hairstyle, body soap application, maybe cut down on a few of the steps. and then recline before or after moving on to the next activity. Moderate. Can this be done daily, weekly? One activity with recovery for breaks. This is just for bathing. Sitting in the bath chair, reclining with elevated feet. And very importantly is keeping your body supported. Support your head, support your torso. Even having your arms extended and working unsupported is very taxing. If you can put something under your elbows, your hands can be more controlled and take less effort. Environment, looking at the lights, the sounds, the smells, and the temperatures. And then the adaptations and modifications. Caregiver assistance for setup. Arranging things very close by, using long-handled sponges and reachers, using pumps for your shampoo instead of having to lift things. Dry off with a robe. You can skip the step of having to dry and then put a robe on. Just use your robe. And then prior to bed, or you return prior to bed and get dressed later. You can be in bed and dress, make that in the next activity. And also using dry shampoo or simpler hairstyles. And severe. This is just for hair washing or body washing, severe. Every few days, maybe even every week or even longer. One activity at a time. Do the hair. Then the next day or week, do the face. Break it down. Do not put them in the same time frame. Physical, reclined in bed, using bolsters and wedges for position. And then the lights, dim controlled lights. Have the individual be able to control with a remote that can adjust the light, the type of light is used. Different shades of lighting is calming and helpful. Visual stimuli, sounds. Is the caregiver's voice too intense? Can they break it down into more signs and using picture cards for what is needed? Smells, taking away the smells. Make things as fragrance-free as possible. And adaptations and modifications, like I said, you use each activity for one particular task. What's the goal? Is it to have the hair washed? Then only do that. Using washcloths and sponges. And also using an inflatable hair tub to wash your hair in bed. This does take some practice, and you might use a lot of pads to make sure that you don't spill on the bed. But using some materials that are in the bed, not far away from the person. The caregiver is going to have to come up with some strategies, and this is what OT is built to do. And then very severe body washes, weekly, every few weeks, or even just do one part at a time. Doing this bedside with very limited touch and very limited movement. Slow, constant pressure. Do not startle the individual. Environment, keeping the lights off, keeping the screens off, visual, taking away patterns, taking away pictures in the room, just keeping things as visually blank as possible. Using cards instead of the voice, smells, and temperature, keeping the body very warm, covering up the body parts that are not being washed or cared for. And then adaptations and modifications, performing routine, predictable movement. Do not start something new without giving the person warning. And then using body wipes, unscented soaps. And again, also this is max assist from a caregiver. These strategies will vary from person to person, severity to severity, but the goal is always the same. improving quality of life. Patients will be seeking OT for services due to the disruption of their occupational roles. Their life has been altered and they want their control back. They need treatment that focuses on managing symptoms, managing activity within PEM limitations, and restoring autonomy. And that is the final of my presentation. I will take some questions if that's needed, Emily.
Absolutely. Amy, thank you so much. That was a fantastic presentation. I really appreciated the breakdowns of examples of mild, moderate, and severe and how the differences can play out. And as we all know, folks with ME/CFS can often transition between those categories, sometimes be mild, sometimes be moderate, and then slip back into severe as well. So I think that's a really important aspect to highlight of this illness. We have so many questions that have been coming in during your presentation. There's lots to talk about and a little bit of time to do it. So I'm just going to dive right in. A question that was submitted in advance of the presentation was specifically about folks who have medical providers who have not heard of OT. How can you convince your medical team that OT should be part of the treatment, or how can you best inform an OT provider that you've sought out how to work with you if they're not familiar with ME?
Okay, so two parts for that. The first is that there are peer-to-peer support groups. So OTs and PTs do not need to reinvent the wheel. That there are some groups out there, they're not many, but there are some groups that are very willing and excited to help train new therapists that are stumped by their patient caseload. So joining physios for ME, even physios with long COVID, they have basic knowledge. They have basic structure and resources, but then also there's a Facebook group of us that's all we do is peer-to-peer. This is, the talk that goes back and forth. How do I handle the situation? And there are modules that are already in the Facebook group. So that group has also a Twitter handle. So we will add that, I think at the end, or provide that resource. It's PT OT for ME/CFS in the Facebook group, but it also is, I saw it pop up on the responses, but it is, it's there for PTs and OTs. Unfortunately, patients are not going to be allowed into the group because it's purely for peer-to-peer. And the second is for patients that are looking to find their local help. I think by saying kind of out loud to the therapist, this is what I need and this is what I want from my care team. The OT and PTs are a patient's employee. Patients need to feel empowered that they can move on to a new person if this person is not going to be willing to learn. And I don't want patients to feel scared of the medical provider. I want them to feel empowered that by, that's what kind of why I presented today is I wanted to give the patients the framework and what they can expect from a caregiver. OTs know what, this is not familiar, or this is not new information to OTs, the frames of references. The structure that I just provided today is new because most OTs do not know what pacing for PEM is. They don't know how to identify it, but by saying, these are my symptoms and this is what happens to me after I exert, I do meet the criteria and I need to be treated from a PEM-sensitive approach. And that's where I think by, reaching out to have conversations, I'm available to help some patients, at least not to help them talk through this. I can offer strategies. I'm not going to be offering direct treatment through this approach, but I know that patients need the language, and that's what I think by providing this type of webinar, I'm hopefully doing.
That does that's so helpful. And maybe a follow-up question to that is, if you're interviewing a potential OT, what are some as a patient with ME/CFS and you're trying to explore that dynamic for somebody who's unfamiliar with the disease, what are some good interview questions that might pop up when you're having that initial conversation about your needs?
I think highlighting that they are having difficulty performing the tasks of everyday living, that they want to, they are motivated to do that, but they need help breaking down the tasks into simpler forms, and maybe not necessarily highlighting all of their whole symptom list. I think they need to prioritize before they go in, because it will blow the therapist over if they went with all 75 of their symptoms. But by a person taking inventory on their own and saying, my first 2 or 5 symptoms are, X, Y, and Z. This is what I would like my therapist to start problem solving with me. I probably could, stand and do this for 10 minutes, but that's not my problems. When I feel well, I can do that. That's not the problem right now. The problem is, how do I do this more with better safety precautions?
And the safety precautions are so critical.
Mhm.
I wanted to share that we had at the room, we being my family, had an OT experience when my mother was sort of starting her recovery journey from her more severe phase into her more moderate phase. And a lot of that had to do with the adaptations that an OT recommended for us in terms of her office space. We completely changed her office space with a reclining bed to put her file folders closer, so she was moving less, not picking things up, putting them up worse, so she was pulling them down, all of these different adaptations, and it really did change her ability to be able to fulfill that function. So I've lived this, and I just cannot stress enough how valuable these insights can be. I know we're running short on time, and there's so many great questions to pull from. I'm just going to pull the last 2, so a little bit of a rapid fire. The first is, how would you modify any of the recommendations that you've shared with us today for children or teens who are looking for these needs?
Well, I'm also my background has been school therapy. So I definitely feel like the team needs to be brought in to understand what the medical needs are and what the actual barriers are. Is this child needing to climb a lot of stairs and work through? But that is its own webinar, is I think schools. But I think children need to still be able to play and find social elements, and that's so important. I think adults get more drawn into what work needs to be done, but kids, I think, need to be prioritized for making sure that they have the social and play elements prioritized, helping parents help your child access their friends through virtual groups. There are a lot of teens out there that have, around the globe found each other. So those type of support groups are not necessarily, something that kids can find on their own, but this is really truly vital, that there needs to be support for kids too.
Absolutely, that's really helpful, and I think those resources you shared will also be helpful guidance for folks who have children with these conditions that are managing them as well. All right, I know I hate to choose questions when we only have one left, but I'm going to choose this question as the last one. So, looking at a patient with severe or very severe ME/CFS, how do you identify their occupations, meaning their meaningful or purposeful activities? For somebody who's already living with that restriction, how do you identify the priorities for what can be unrestricted as you start moving towards more activities of daily living?
Well, unfortunately, I think a lot of the self-care or care tasks are the priority for patients that are severe and very severe. Unfortunately, their windows have been withered down to the core elements of that. I think by taking care of those, like you had said earlier, when somebody is not stressed and strained, They are more stable in like your mother, more stable in their severity level. They then can start broadening their window a little bit. So I think by people that are severe and very severe, that window is so narrow, but just by taking care of their digestion and their environment, their immediate environment, they can start adding a little bit more quality. Maybe it's being able to listen to a song that they once liked. Just doing something that's very, very minimal is, I think, kind of the level that it's at. But taking away every amount of effort that they're going to have in their bed, getting their bowel movement more or less as stable as in routine as it possibly can, because we know that that affects a lot of sleep, and it's just keeping things as basic as possible, and giving nutrition and all of the supports that possibly can help with all of their systems.
Fabulous advice. Start with stability and kind of work outwards based on priorities from there. I think that's so helpful, and really, I think there's a lot of folks out there who are going to be really benefiting from that advice. Amy, I hate to cut it short, but we are out of time. This has been so insightful, amazing. I've learned something new, and I thought I was familiar with this field. So I just wanted to thank you for sharing your expertise. Again, for folks who have joined us, we'll be sharing your questions with Amy afterwards, and that there might be a follow-up, but definitely this has been recorded, and you can always find it on our YouTube channel, and our other webinars that are coming up will be on that YouTube channel as well. Amy, thank you once again. Any final thoughts to leave our audience with as we wrap up?
Just that people are out there to help, and I think just keep feeling that there is hope. Things are coming around the corner, and I'm doing my best to try to get the OTs and PTs out there to know this information. So we're hopeful, and just stay with us.
You're not alone out there. Stay with us. There's help on the way. Great messages. Thank you so much, Amy. Thank you all for joining us for this fantastic webinar. More will come. Hope you can join the recording on youtube.com/solvecfs. And we look forward to joining you at the next webinar in our series. Thank you all so much for your time. Have a wonderful day.
Thanks. Bye.